We're good.
We are good. We are broadcasting. The webinar is opening and people are coming in. Welcome, everybody. Sorry we didn't get this opened up a few minutes early like we normally do. We've just had some technical issues with the internet here today on some sides. So welcome to the Washington AGD Stay Home, Stay Healthy CE series that we have put together. We've been doing this for weeks now. And it's been very, very successful, except for the fact that my screen doesn't want to move. So let's try that again and see if we can get that. Eric, thanks for raising your hand, but we're not going to do any with the thing with raising the hand here today. If you have questions, you can put it in the Q&A section there. Let's just see if these slides will advance for us. Otherwise, okay. Okay, welcome. Washington Academy of General Dentistry, Stay Home, Stay Healthy CE series. We are on webinar number 14 for the week. So thank you for those of you that have joined us on multiple days. Thank you to the International Academy of Nathology for putting together a great program on Monday. And we'd like to thank the Arkansas Academy of General Dentistry for putting the speakers together on Tuesday. And we'd like to thank the Canadian Academy of Restorative Dentistry and Prosthodontics for the speaker series yesterday, Thursday. That was wonderful. We will be having a whole slate of webinars next week. We just don't have them all up on our WashingtonAGD.org page yet. We're working on those this afternoon. Those should be up either by this evening or tomorrow sometime. So check back. That's WashingtonAGD.org. You'll see some of these flyers. These webinars have already happened this week. You can see those webinars at YouTube at Washington Academy of General Dentistry. Also, go to Facebook and you'll see upcoming webinars there as well. We actually can get the information onto Facebook faster than we can to our website. So that's a great place to look, and make sure you, whether it be YouTube or our Facebook page, like us so we can keep you informed of upcoming courses, seminars, etc. This afternoon, Dr. Yassin is going to continue his implant study club. Just a reminder that in the fall, he's going to start up the implant continuing again. Remember, that's 240 hours of CE, all dedicated in the placement of implants. That's a hands-on course. And I think we have a few slots still available there. There is a discount for being an AGD member and participating in that course. Thank you to Dr. Karbash for presenting this morning on COVID-19. Remember, she will be answering questions next Tuesday afternoon based on the Q&A that we received today and that we were not able to get to all the questions. Just seeing how many we have in here right now. Well, we're about at 350 so far. I know we have some more participants. We're just going to give it a couple of seconds here before I have Dr. Yassin introduce his colleagues, his panelists for today. I'd like to thank Comet USA for their sponsorship and Patterson Dental, as well as the Canadian Academy of Restorative Dentistry and Prosthodontics, and of course the University of Washington School of Dentistry CE department. You will be receiving your CE credit via the University of Washington. You will see that CE credit appear in your inbox at the email that you registered for this study club today. So that should show up in 2 to 3 days. There'll be a PDF there. It's not personalized for you. Please just put your name on that, save that for your records. If you are an AGD member, we'll be reporting those CE credits directly to the Academy of General Dentistry on your behalf. I want to thank our panelist, Dr. Gary Hayamoto, who sat through all these webinars with myself, and our executive director, Valerie Bartoli. I'd like to thank our website manager, Dr. Pressett. Appreciate everything you've done for us and keeping on top of this stuff. Remember, the Washington Academy of General Dentistry, we have a wonderful educational center here at SeaTac that's right at the airport here between Seattle and Tacoma. We can host live events. We can host hands-on events. That's where we're hosting our orthodontic program and our implantology from A to Z. And there's the flyer right there. So use that QR code. If you didn't get that QR code, just go to washingtonagd.org. In the future, please come back to our webpage. We will be working on-demand CE so that you can actually watch CE and get credits from the comfort of your own home. No need to travel. Well, I think we've got the vast majority of people into the webinar here today. If you have questions, put them in the Q&A section there. Dr. Yassin is great at moderating his own Q&A, so we'll let him do that. And with that, I'm going to ask Dr. Yassin, could you please introduce your guests today?
Thank you so much, Dr. Hess, and welcome everybody to our part 4 of Implant Study Club online. It's been a great pleasure with a lot of work from the Washington Academy of General Dentistry. Today is the part 4 of this series. We covered a lot of great topics. Today we have 2 exceptional speakers joining us from the United Kingdom, Dr. Victoria Ivancheva. Welcome, Victoria.
Hi, Alan.
Thank you. And from Canada, Dr. Shahdad Ayoughi. Welcome. Yeah. Quick introduction today. We will be spending 2 hours in this webinar to cover 2 very important topics. Dr. Ayoughi will start with autogenous tooth bone graft for socket grafting and ridge preservation. And then following this talk, we will have Dr. Ivancheva talking about the temporization in implant dentistry. So very exciting. Just to remind everybody here that this is the Implant Study Club still have 1 more session to go on Wednesday, May 13th. Is going to be with Dr. Brian Brancho to cover the soft tissue management and implant dentistry. If you missed any of the past 3 sessions, you can go to the YouTube to watch them and connect with the Washington Academy of General Dentistry if you have any comments or questions. As Dr. Hess said, we are broadcasting from Seattle, Washington. Seattle is located at the northwest of the United States. Washington has been great with this pandemic. I hope everybody's staying safe and healthy. I think we're in a good route right now. Hopefully we'll be going back to work in Seattle soon. I practice in Seattle, so if you have any questions, please feel free to reach out by email or join me in social media if you have any of questions or if you want to claim of any of the literature that we'll be discussing today. As Dr. Hess mentioned, we have in Seattle a great solid program that we have been doing for a couple of years. We'll go back to our June session, but we're already planning our 2021 program. It's a clinical implantology from A to Z, 10 modules. Take a look at at our website also. It's clinical, live surgeries, and hands-on program that we offer. Not only full program, you can choose some models if you want to join us with this. So please take a look and let me know if I can be in any help. Our participants last year we have, or still this year, we have full-timers, doctors that they enjoyed and still enjoying doing live surgeries, placing implants. We have this great facility at the SeaTac area. back to our topics. I will be introducing this concept. I wanted to join two topics of doing preserving of the bone and preserving of the soft tissue. We'll start with Dr. Ayoughi talking about the socket grafting, utilizing this unique technique of using the extracted tooth and autogenous tissues to graft the socket and preserve the bone. And then it's linked with the temporization, where we can support the soft tissue and we will have the soft tissue, the thick, nice, stable soft tissue will support a stable bone and vice versa. So I'm gonna go back to Dr. Ayoughi. Dr. Ayoughi practices in Vancouver, Washington. He's been a great friend for me. I've been following his work. He's an exceptional practitioner. So welcome, Dr. Ayoughi. Thank you for joining us. I'm gonna stop sharing my screen, and I'm looking forward to take a look and watch your presentation.
Thank you very much. So I'm gonna share my screen. Thank you for that introduction, Dr. Est and Dr. Yassin. I'm gonna try to share my screen here with you. There you go. And let's do it. Okay. So today we are talking about the tooth as autogenous bone graft, and not only for the socket, for ridge preservation and vertical and horizontal augmentation. So welcome everyone to this amazing set of webinars and presentations online. As Dr. Yassin said, I'm from Vancouver, and it's a beautiful city. Hopefully all of you guys can come and visit if you haven't already, after this challenging times is over. Extremely honored to be here with you guys and present at this great event. I'm following it. It's amazing. And all of the Dr. Yassin, of course, great friend and colleague for years. Really, thank you for inviting me here.
My pleasure. Thank you.
Absolutely. So disclaimer here, obviously I'm not sponsored by this company. Unfortunately, they are not paying me for any of this products and machines that they are selling. So I'm not sponsored by any of this companies or the material. We all know it's a challenging time. Cities are empty, but good times are coming, and it too shall pass. So stay safe wherever you are. And soon we have to go back to our practices like astronauts, I believe. I'm not sure what's going to be the PPE. This is the word that is very common these days, but what is PPE? I don't know. So we will find out. I think this is the future of dentistry, and this is how we're going to practice from now on. Well, hopefully not. So I was thinking about this presentation, and I wanted to talk about something that it's for everyone, not only for people who are doing implant or implantologists, but also for like general dentists, for everyone, whoever is doing dentistry. I think the first thing we do is just we pull the tooth, or that's the first thing we learn at the school. So this topic is for everyone. And particularly in this period of time, it's important because financially, it can help our offices immensely. And I'll talk about it more in a minute. And also, this is not a new subject, and also it is a new subject. So it's a new and old. A lot of colleagues like Professor Binderman, Ziv Mazor, Dr. Son, Dr. Paul, Rick Meyer, many people worked on this, extensively. And this is a subject that is very well researched. So we can use tooth and dentin as autogenous bone substitute material. And again, not only for implantology, just for day-to-day dentistry, it's an important subject. We all, as dentists, we try to save teeth, and this is our goal. I think we all go through training to save teeth, but at some point it's going to be end of the road and we have to pull tooth or either part of it. So I personally love to save the tooth, like all of you guys, I'm sure, but at some point we have to pull it. And at that moment, I prefer to use socket shield or partial extraction therapy, which is a great subject to talk for another presentation. But partially or entirely, we pull the tooth, and we all know that it's a fact that when we pull tooth, we lose bone. You know, it's simply we lose height and weight of the tooth. Bone. And it's a functional matrix that we are dealing with. So when we don't have tooth in the bone, bone starts to resorb and soft tissue follows, and neighboring teeth start to get affected, and our occlusion and vertical dimension of the face and facial symmetry and everything else would be affected after a tooth is lost. You know, as you can see in the slide, and you guys already know it, we get over eruption of the teeth on the opposing arch. We're gonna lose gum, and three-dimensionally we lose bone. So if the implant would be the treatment plan for now or future, you know, we don't have to do the implant right away, or it's not treatment plan yet. We know with no bone we cannot put implanting. It doesn't matter how good the connective tissue is, or level of the sinus is, or any other thing is irrelevant if we don't have bone. We need three-dimensional bone around the implant. That's where the implant starts. So, and we know the patient's own is the gold standard. That's a given. We all agree on that. When we extract a tooth, as we all know, between 3 to 6 millimeters of the bone three-dimensional would be lost in the first year. Up to some studies show 25% of the bone would be lost in first year. And there are a lot of chewing issues, health issues, which I'm not going to go to detail of all of those because we all know about it. It's very interesting to mention here. We did Dr. Paul did a CBCT volumetric study and showed that when we use tooth, like dentin and tooth grind and use as particulate to graft the extracted socket, we have the best result compared to any other material, especially on the buccal side, which is particularly important in aesthetic zone. So why tooth as a bone graft material? First of all, it's there. Don't have to order it, don't have to buy it. And we get great result. And long-term predictability is probably one of the best of all of the materials that we have. And patient would be much more happier for reasons that we'll talk about it. And of course, we use patient's own tooth. I got some questions about that. It has to be exact same patient. When we use tooth as bone graft material, volume and quality of the bone is superior. We can mix it with other graft material. We can mix it with allograft or xenograft, another material. Mix it with blood or PRF or saline, so handling is great. And osseodensification can be done when we use tooth as bone graft material, because sometimes, for example, if we use xenograft material, then osseodensification, which is again another great subject for a conversation for another time, it's questionable. But when we use tooth, osseodensification can be done. And success rate is really high and healing is much faster. And we will talk about it in a minute. We can use tooth as particulate, we can grind it, or we can use it as a laminate, which is very exciting, or we can use it as a ring, which is amazing way of using tooth as bone graft material 3-dimensionally. We can use it for socket preservation or vertical or horizontal augmentation. So it's pretty much a versatile material that we can use in all aspects and all applications. So message here is when you pull the tooth, don't throw it away. At least you save it. We can save it and we can use it later on. Even if you don't use it as a graft now, we can use it later. So we can talk about that in a minute as well. So in this particular time, I mean, all of us, we are out of the office and we are not working, we are not seeing the patient. All of our expenses are there, and financially, dentistry is in trouble. I mean, this is a fact. And bone graft material, doesn't matter how you get it, in which province, in which country, and in volume that you buy to make it the discount volume, but still it's expensive. I mean, none of the bone graft material are cheap. And we all know at this time, we don't have the patient flow and production that we had before. So anything can save money and add to the production. To me, it's important in this day and age, and you know, to the day, for the days to come. So for any graft material, let's look at the graft materials for a second. I'm not going to go into detail of everything. It's a short presentation, but any graft material, it has to be biocompatible, and it has to trigger all of the healing that we need for having a good graft and turn over to the patient own bone. It should not be rejected, obviously. And pain and inflammation, these are the factors, plus other factors that are important, but these are important factors as biocompatibility of the graft material. And it also has to be bioactive, and it has to work with the host, with the body of the patient, and communicate with the material and the cells, and hopefully create new bone. And it has to be osteoconductive, or ideally a graft material that has to be osteoconductive. So stay there long enough to create a scaffold for the bone to come and form there, and, you know, support vascularization. There are so many graft material out there that they're going to be resorbed really fast, or they are not supporting vascularization. And one of the most important thing a graft material should have is osteoinductivity. And I'm sure Dr. Yassin can talk about it in the later on, which is ideally, if you have the graft which is osteoinductive, it's amazing. And when we use tooth, and which has the patient own characteristics, it has lots of BMPs and growth factors in it, which is really a great bonus if you use that. And don't forget, all of us, or most of us, all the time, or most of the time, we pull the tooth and we throw it away, while we have all of these great characteristics here. So this is very well studied, and it's in literature. It's not just an idea that was born yesterday. It was studied very extensively. And to me, and I think for most of us, histology is the key. We cannot just put the material in the bone. There are some perioglast, for example, they put it in the socket or do the you know, bone graft material, that it looks good on the X-ray, but when we look at the histology, it's useless. But dentin, as you can see here, a piece of dentin, it has to be here. See, that's a piece of dentin, and we got the bone regeneration and bone remodeling around it. So this is a histology, and this is the proof. And there are a lot of histology has been done, many studies that show this works. When we use graft, again, biocompatibility, bioactivity, osteoconductivity, and inductivity should be there. And histology shows that autologous bone graft material, which comes from the tooth, it has all of those characteristics here. When we use dentin as bone graft material, we get ankylosis. That happens after the grafting. It's very, very stable. It's not gonna be resorbed and go away really fast. At the same time, healing is very fast. So we can go back and place implant or whatever is the treatment plan. We can do it faster than most other materials. We get a lot of growth factors in it. We get a lot of BMP, and it does generate new bone fast, and it's bioactive. Again, we talked about it, and accelerate and regenerate new bone. Soft tissue and hard tissue, because when we have the natural bone, soft tissue follows, and we get a good soft tissue in the area. It has very slow resorption characteristics, so it's not going to go away, and soft tissue invagination not going to happen that fast, which is great. Dimensions are stable and very predictable. And like I said, patient acceptance is really high. The other advantages that we have here when you use tooth, like patient's own tooth as a bone graft, is no cross-contamination. So in my practice at least, and I'm sure many of you guys, when you do the bone graft, we get this question all the time, that where is this bone coming from, or this bone graft material coming from? There is no cross-contamination. Patients like it because of that, and it has the same biological characteristics, and no manufacturing preparation problem can happen when we use tooth. And the other thing in this particular time is important is the shelf life. All of us in our offices have materials, thousands and thousands of dollars of material, not only bone graft, we have composites, we have, name it, we have all sorts of material in the office that the shelf life of them can be a problem, can be use all of those materials in time. We have been closed for months now, for weeks, and in some areas actually for a couple of months. So when we use tooth, the shelf life problem, it doesn't exist anymore. And this is the only autogenous bone graft material that I'm aware of that does not need the secondary harvesting site. For all of the autogenous bone graft material, we have to harvest it from somewhere. But this one, when we use tooth, that problem is gone. I talked about patient acceptance. When we talk to the patient that we can use their own teeth or tooth as bone graft material, they love it. We know it's most cities and most of our practices are multicultural. And for religious reasons or cultural reasons, some people do not like bone from a dead body or from animal and from other sources. And when it's from their own body, they like it much better. And there is no immune reaction or adverse immune reaction to the bone graft material that comes from tooth. And pain and inflammation subsequently would be less. And it's cheaper. And as I mentioned, there is no second harvesting site. Again, because it's important, I put this slide here. We have to understand that we get a lot of growth factors, a lot of BMPs, and superior results. Let's look at the case here. I didn't have access to all of my cases because of current situation, but I put some cases here. For example, Bob, he's 67 years old, he's non-smoker, but he's diabetic, and he did not like to get bone graft material from, quote unquote, dead person. So lower right molar, as you can see here on this pan, we had a deep caries we discussed the option with the patient, and patient decided to pull it, but he wanted to get implant there. So you can see this tooth had the caries and composite in it, decided to pull the tooth. Pull the tooth. We cleaned it, which I'm going to talk about it. When we do the cleaning, physical cleaning of the tooth, we have to be careful. It's very easy. First of all, we can use anything like high speed, slow speed. So we physically clean the tooth, which I'm going to speak about it a little bit more in the protocol. Put it in this machine that I use in my practices. It's a small machine, looks like a coffee grinder. Put the tooth in there after the cleaning for 3 seconds, and we grind the tooth, and we get the particulate. It has 2 drawers for those of you guys who haven't seen it. On the top drawer, we get the grind material. On the bottom, on the bottom, we get the graft material, and on the bottom, we get the smallest particles. So after 3 seconds of grinding and 10 seconds of filtering, get the graft ready. We put the liquid number 1. Again, with this system, we use this. Liquid number 1 is cleansing. Put it there for a few minutes. Then we dehydrate it with the gauze, and graft material is ready. I'm going to show the protocol later in detail. In this particular case, we did the ridge split as well. And specifically, I wanted to show you that we can use this material or dentin grind in combination with other techniques as well. So split the ridge, and we place the implants here immediately after extraction. I use the membrane. Usually with dentin, I do not use membrane, especially if the periosteum is intact. I don't see the need for membrane, but here we had the molar extracted, so I wanted the wound to be completely closed, so we use the membrane here in this case. Again, I want to show different cases and different techniques. Implant in place. The 2 implants here. Grafted, membrane over. And all of the principles apply. We have to have tension-free closure. I check implants with the ISQ, and I want to make sure that the stability of the implant is there. It's a great machine that I use and I love it. So ISQ number is 77, stability of the implant at the beginning. This is the X-ray after 8 weeks. So in 2 months, you can see the quality of the bone and the, okay. So this is after 2 months. Soft tissue. I wanted to improve the quality of the soft tissue. So we had the luxury to go back and do the re-entry, look at the bone. We did the soft tissue graft. Bone was really good. This is after 4 months. You can see really good quality of the bone around the implant and over the implant. Healing. And you can see the ISQ numbers substantially go up. We have a very good quality of the bone and implant here, the implant stability here. Go up to 85, those guys that use ISQ number. And the final result. Excellent soft tissue and hard tissue quality. We have a number of these cases. They're amazing, and patient was very happy. And that's the final. You can see the quality of the bone around the implants. Over the implants, we have bone. This is another patient, Pauline. She's 81 years old, osteoporotic, non-smoker, and she's a retired nurse. So she asked questions about the bone and bone graft material to no end. She wants to know where is it coming from, what's the origin of it. She has a little bit of problem with that person bone in her body. So we had to pull this tooth. I'm going quickly over these implants, but there's something I wanted to pay attention in this x-rays, that I had placed implant for Pauline many years ago. As you can see here, this is the old implant. There's no pre-implantitis or any reaction here, but I can see bone is remodeled around this implant. So we pulled that tooth and cleaned it. Not much left. Put it in this machine. The smart denting grinder, very small amount. But she wanted her own, so we got this much material out of it. I think it's outstanding. It's great. Any other material that I wanted to use, first of all, was not autogenous, and second, it would be expensive. So dentin cleanser, liquid number 1. Again, we did the soft tissue graft here. And okay, past this one's healing of the soft tissue, and we grafted. So this is the x-ray after 9 weeks. So a little bit over 2 months. You can appreciate the quality of the bone here on the x-ray at least. And this is after 5 months. Very good dense bone there. And place the implant, and this is the x-ray 4 months after the implant. If you look at the implant in front of the new implant, the one in the mesial, premolar, look at the x-ray of before and after. Because I had extra material, so I grafted that too. So I cleaned it, I removed the crown, I put the graft material around the implant on the mesial, and look at the healing of the bone on the implant on the mesial. The old implant is like 10 years old. So got the excellent result here. And I know this is a periapical x-ray that we are looking at versus between, but still you can see the level of the bone is improved drastically. And we got the stability of 82. So amazing result. And this is another machine actually I use. Again, I'm not sponsored by them or anything, any check. Don't know if Dr. Yassin used it in the course as well or not, but we used to, now you know how old I am. We used to use mirror handle and go tap, tap, tap on the implant and say it's integrated or not. So it was pretty much what we had in older days, plus the x-ray. Now I use this any check machine. It just showed the stability of the implant, even if it's the prosthetic is on it, is the healing cap is on it. So it's a great machine to check the stability of the implant and monitor it. So 81 is really high. Again, with same as ISQ, it's from I think 0 to 100. And these are the x-ray of before and after, at the time of the extraction, and 4 months after the implant went in. So before and after, extremely good result. And the bone quality and volume around the old implant is much improved as well. All right, how are we doing with time? I'm gonna go a little bit faster. So question, that tooth and bone are similar or not? They are very, very similar. I'm gonna go quickly over this, but the composition of the tooth and the bone is very similar to each other. As far as the organic and non-inorganic material, the amount of collagen and hydroxyapatite, bone and tooth are very close, and I'm not going to go into detail. The most important thing probably is we have a lot of BMPs and growth factors in it. And the protocol with this machine, with a smart denting grind, is very, very easy. In just a few minutes, we get the bone graft material out of the tooth. We pull the tooth, we clean it. You can use high speed, slow speed, piezo, or anything, but make sure there is no cavity or decay, no composite, amalgam, or anything like that. So we just clean it, in 30 seconds or so. We just clean the tooth, remove all of the restorative material, dry it. And this is how the kit comes with the smart grind machine. The top part, the coffee grinder part, this part, and the jar and this liquids, they are disposable for one patient only. I don't know, the price is around $50 to $60 per kit, so you can get as much as bone graft you can from one patient. In full mouth or full arch, we extract bunch of tooth, 1, 2, 3, 4, so we can get a lot of bone graft out of it. Excuse me. After cleaning the tooth, we put it in the grinder, grind it for 3 seconds, and we get the particulates of 300 to 1200 nanometer particles, which is excellent size for grafting, for bone grafting. And depends on the tooth, either is incisor or molar, you could get 0.5 to 3 cc's of bone graft material, which is great. And if you have multiple teeth, obviously you get more. 5 minutes of liquid number 1, which is dentin cleanser. And then we dehydrate it with a gauze. And we put liquid number 2. Basically, we wash it twice for a few minutes, and you have the bone graft ready. Just simple as that. It's in like few minutes. What we get out of this, well, first of all, we don't need to remove all of the enamel. Enamel gives us something like xenograft quality. It's hardly resorbed, and dentin gives us a quality of cortical bone, and cementum gives us quality of cancellous bone. And there is a new protocol with the same company and same machine that we get partially demineralized dentin, which has better quality, as in fastest growth factor release and faster bone regeneration. I'm going to go to another case very quickly. She's like 90, almost 90 years old. She had implant before. You see here, we had to pull like 5 lower anterior teeth, cleaned it, grind it, and I used it with PRF as sticky dentin, as we call it. Go very quickly. You can see the healing. This almost 90 years old. And go to the final. So really good hard tissue and soft tissue quality. She had other implants from another dentist before, not a great hygiene, nor she is healing really fast, but with dentin grind and dentin bone graft material, we got excellent result. As I said, there is a new protocol with this particular company. They came with the EDTA that we use it for 2 minutes after cleansing. And as a result, we get more growth factor release and faster healing. Really works. It just, all we need is 7 to 8 minutes. And my awesome staff, that I really thank them. I think all of us really depend on excellent staff that we have. So my staff do it in just a few minutes, and we got the bone graft. This is the how they look under the electron microscope. I'm not going to go through all of these. make it a short presentation. These are thanks to Dr. Pinto, Nelson Pinto. He did a lot of histology study on that. Cleaning the tooth. Going over this faster. How are we doing, Dr. Yassin, with time? I think we are almost there.
Yes, we have another 10 minutes and then we'll address some questions. We have a lot of questions coming in.
Go really fast. I think we covered at least the basics, so we can cover. This is another case, courtesy of Dr. Lee. And this is very, very exciting. I really love these techniques. I mean, he doesn't use the same machine that we use, but the principles are the same. So he grind part of the tooth. He used part of the tooth as you know, onlay graft and particulates, mix and match it. Excellent cases. We're not going to go. There's another case I want to show you quickly that we use this one, that we can use tooth as a ring technique augmentation. So three-dimensionally, we can graft bone around the implant, which is very exciting, and it works. So we clean the tooth, we make the ring out of it, place the implant in it, and place it in the bone. And there you go. You can see vertical and horizontal augmentation, ring technique around the implant at the same time of extraction. And this is Dr. Son in case. There's another machine that it's from Korea. I have not used it. This one, it's much more expensive and more, much bigger actually, but principle is the same. So he used it here as a ring technique for the implant. Amazing technique. You can see here, it's demineralized tooth ring bone. And that's the result. So the three-dimensional bone augmentation around the implant. Sticky dentin, same principle. We can mix it with PRF. I'm not going to go through detail, but handling is pretty much same as any other bone graft material, even better and more superior. So use it with the PRF. Another case. The sticky bone. Gonna go quickly over these. And it was another patient. He was a type 1 diabetic, and we got bone loss as well. So it was the technique of choice, at least in my practice. I thought that it's best to use his own tooth or teeth. Grafted, we got excellent result here. And don't ask me what's that piece of metal here, because I have no idea what this thing is. For the life of me, it came on the x-ray and gone, and it showed here. But anyway, we got a very good bone quality here. Using tooth and dentin grind for treatment of pre-implantitis. I don't know. I mean, I have enough cases to show you that treating the pre-implantitis with any material, it's a good idea and it works. And I have more cases to show you that treatment of pre-implantitis with any material, it doesn't work. So I think we are still have some ways to go on treatment of pre-implantitis cases. But this is a case that we used dentin grind. It worked very well. But don't quote me on that, because this is a subject I would like to work on it more, like all of us collectively. Right. Good result. So in conclusion, it's best to graft almost all of the extraction sites because we lose bone and facial symmetry, and a lot of dental, oral, and general health issues come after extraction of the tooth. So most of the extraction sites is best to graft them. I'm not talking about wisdom teeth in some cases, but most cases anyway. tooth works same as bone graft, even better, and actually much better. It's easy, it's fast, it saves a lot of money. It creates actually a lot of production and money as well, because after we extract the tooth, we can graft it. I don't know about some countries, but at least in Canada, most insurance companies and most patients actually would love to preserve the bone, so they pay for it. So on top of extraction, you can graft the bone, no expiry date, and it works very well. And soon, good day, it's impossible not talk about this period of time. We used to travel, we used to go everywhere without even thinking about it. We jump on the plane and go to any of the meetings. Now we go to grocery store. We have to think twice before we make that trip. So good days are coming, I'm sure. And this is a slide I really like. Nowadays, there are so many information online. There are so many webinars, there are news, and I'm not talking about only dentistry, about everything. We get like a lot of information online. But always remember, what you see, it's not exactly what it is. So ask questions, look at everything from different angles, and try to understand what's real and what's not. And I have to thank to all of our heroes. We have to thank them. These are the people keep us safe. And during this time, they help us to have our lives uninterrupted. All of the truckers, all of the grocery workers, of course, nurses, doctors, and many other people who are invisible, but helped us during this time. I put my email here as well, in case you have any question. There are a lot of references here. And there you go.
Thank you so much, Dr. Ayoughi. This is
very welcome.
This is a great presentation.
Turbocharge. I went really fast.
It's a lot of information, I know. So we covering the bone grafting. Usually in my course, we have 3 days full of bone grafting work and discussion. I have a lot of questions to address. Some of them came to my mind, and I'm gonna be sharing. So if you don't mind going through this, is there any histology studies showing the bone grafting extracted from teeth after generating bone? Is there any histology study showing exactly what kind of material we're having after using this bone from the tooth extracted?
Yes, it has been very well studied. I showed a couple of histology slides. I'm sure you saw them. And at different steps in animal, in human. In some case, we had the luxury of going back because we wanted to place implants. So we could, and I showed some slides from Professor Pinto that he went back and used the terrifying, got the bone out before placing the implant. And yeah.
The associated question was, does the socket classification after extraction really determine what kind of bone we're getting? If it is a class 2, we lost the buccal bone, or if it is a class 1, does this really matter in this technique?
Well, it has been an excellent question, actually, because like I said, Dr. Paul did a study in Europe, and I think it was a collaboration with university in Egypt. They did this study, and it has shown that bone graft material coming from dentin, like tooth, dentin grind, was the best material in preserving the buccal bone or regenerating and preserving the buccal bone. So all of the other materials showed more resorption and more remodeling, but dentin grind was the best.
Right. There was a lot of questions about membrane. I just wanted to touch base and tell everybody that using this tooth bone graft, Autogenous, is will follow the same bone grafting techniques that we do all the time. So using membranes is similar, and we want to just make sure that we are building the bone, preserving the ridge, and following the what we know from bone grafting. Some questions, Dr. Ayoughi, went with root canal, either by root canal tissues or root canal treated teeth. So any comments about this?
Great question. I always get it. The root canal T was absolute no before. And with the same company, which is under study of Professor Binderman, I'm sure this name everyone knows him. When he came up with the smart dentin grind idea and everything, root canal teeth was a no. So we didn't use them. We just chucked them. Now they say you can use them. They did some study on it. They say you can use it. You have to clean it, make sure there's no gatoperca. Obviously, everything is cleaned. I personally, and just my personal opinion, I do not use root canal teeth for bone graft material simply because I cannot make sure that I cleaned it completely, 100%. I don't know what was the sealer there. Did I clean all of the sealers in the tubules or not? So I don't trust myself to use root canal teeth. But they say yes, you can now.
Yeah, personally, I don't really use the technique, so I think that makes sense. A lot of questions came to contaminated teeth or decayed teeth. I think any technique will still have limitations, right? So I think we should be really careful. It is a new old concept, right? So it is. Yeah. We still need to know more. We need to have more research, probably more evidence-based clinical trials to know exactly the long term for it. But I feel that it's feasible to avoid any severely decayed or diseased teeth. So what's your take on this?
I'm using it for a few years now. Decay, I don't mind. We remove all of the decay, obviously. Okay, any caries, we remove it. Extremely damaged and decayed teeth are fine. We can use them. Necrotic teeth, we can use them, no problem. Teeth with periapical abscess or something, we can use them, which are the most of the time is the tooth that we pull anyway. Either they are extensively carious or they have periapical lesion and pathology. So as long as we clean them and remove all of the abscess and caries, and we just get a clean piece of tooth and dentin or whatever left, that's fine. Yeah.
Perfect. Yeah. Another question is if the patients opt to do the treatment later on, what's your protocol to save the teeth and sterilizing the teeth for later?
We can, again, another good question, because during this time, we had to do some emergencies and pull teeth, but we did not have the luxury of grinding them and putting them back together. So what we do is just clean it, okay, with alcohol, just very simple cleaning, putting it in a box and save it forever. For the lifetime of the patient, we can save that tooth, and we can later on grind it and use it for the same patient.
Is this the same for fractured teeth also?
Yes.
Same thing if you have the same thing.
Yes.
I had.
You're not using the tooth right now, even if you're not grinding it and grafting it back, save it for later, because who knows, maybe in some other part of the mouth, maybe a patient has a fractured tooth, like you mentioned, at the front or wherever, and we can use that pulled tooth later on.
Yeah, that's amazing. A couple of other questions. What is the amount of material we can get from one molar, for example?
We can get anywhere between, I think I put it in one of the slides, anywhere between half a cc to 3 cc's of graft material. If it's incisor, obviously we get less material. Whereas if there's a molar or multiple teeth, we can get more. But one tooth between incisor or molars, we can get half to 3 cc's of bone graft material.
Awesome. I have a lot of questions coming about the cleaning protocol for you. So after doing the extraction, and I know that usually you have a solid assistant working with you with the machine. So if you can just touch base a little bit with the
very easy,
steps.
actually. Cleaning, cleaning part is very easy. You just clean it with high speed. See here, high speed, the slowest speed. I use high speed, just clean it, remove all of the restoration. So no composite, no amalgam or anything like that. And that's it, no caries. Just maybe 30 seconds or 1 minute, you can do the cleaning.
Perfect.
Yeah.
Some technical or practical questions. Do we use the same socket grafting ridge preservation codes for this technique?
Yes.
Yeah. I think if you want to add any membrane or something, you can add it.
Because you know, any bone graft material that we use for like 1 cc, at least in Canada, it's roughly $200. But when I use this and my cost is only like $50, $60, there's a flexibility for me to pass it to the patient as well. So it's less cost for me. You know.
Perfect. Would you prefer to autoclave teeth? You know, and if you want to.
I don't think it's necessary because when we clean the tooth with the solution number 1 with the cleanser, all of the pathology and everything would be gone, and there's no need for autoclave it.
Right.
Yeah.
Absolutely. Any other questions? I have a lot of questions coming in. So, yeah, it's an amazing topic how to utilize this. I think some of the questions using teeth for other patients, Dr. Ayoughi already mentioned this at the very beginning.
Yeah.
It
was, I think, if I'm not wrong, I found only one study about the identical twins. And in my practice, I don't get 2 identical twins coming at the same time. So I pull the tooth and put it in the other ones just for the sake of research. So just same patient. So stick to, I get the question, can I use it for my wife? And so, well, if you want to kill your wife, your husband, sure, but don't.
Okay, so last question. I have a lot of questions coming on. We tried to answer most of them with my knowledge. As I mentioned, I don't use this technique on a daily basis.
You can always email me if there's something, you know.
If you have any questions, also we can reach Dr. Ayoughi. But the last question is, what's your take about enamel with you know, the dentin histology is closer to the bone, but with the enamel involvement is a little bit different. So what's your understanding or your take for this when you grind the whole tooth together?
You do not need to remove enamel. Okay, as I put it in this slide, enamel does not resorb in my personal experience and in all of the research that I could see, and it gives you quality of the xenograft bone, which almost never resorb. So if we mix it together and we put it back, use it as graft material, it's fine. You know, we get some enamel particles in it as well, so no problem.
Perfect. Yes. Well, thank you so much, Dr. Ayoughi. I appreciate your presentation.
Absolutely.
And it's been a great to have all this information together. If you have any questions, guys, Dr. Shahdad Ayoughi already provided his email address. You can email me or email himself for answers. It's a big topic. I think it's really important for us to follow some of the structures that we know about bone grafts. Thank you so much, Dr. Ayoughi.
Thank you so much.
I will start sharing my screen for a minute here, and I just wanted to touch base of couple of things that we already discussed last time especially when we talked about extraction with Dr. Rasner. Uh, um, Whenever we do any extraction, we either go with an immediate implant placement or some bone grafting, or do nothing in general. One of the most important thing for anybody using the extraction, minimally traumatic extraction concept, is to understand the science behind it. We have two different classification for teeth extraction and socket grafting. We have the classification for the tooth positioning inside the alveolar bone, and we have the classification for the socket after the extraction. Our main goal is to keep the bony wall, the soft tissue, available before the extraction, exactly after the extraction. So this is how we say when we talk about minimally traumatic extraction, what I like to call it preserving safe extraction, is to make a good diagnosis for the extraction site for the tooth and the alveolar bone before doing the extraction. The sagittal CBCT section is really important, especially in the immediate implant placement. Classifications are a lot for either tooth positioning inside the alveolar bone. One of the best is Can and colleagues in 2012, which will classify this for 4 different types. And also after the extraction, the socket, extraction socket after the extraction, we have several classification. One of the most important thing is to recognize, try to save as much as we can from the buccal bone. If we have a type 1 tooth positioning, keep it as is without really losing any of the tooth around it. Dr. Ayoughi mentioned a little bit about the bone graft. He talked about the autogenous bone graft here. This is the classification for our bone graft that we know, either autogenous bone graft from the same patient, the allograft from other humans and cadavers, the xenograft coming from other species and animals, and the alloplastic materials as synthetic bone. It's really important to understand the process of creating bone through the bone grafts. We have 3 different processes: osteogenesis, which comes from autogenous bone graft that Dr. Ayoughi already mentioned, and for a long time, the autogenous bone graft was the golden concept for bone grafting for a long time, back in the 90s, especially early 2000s. And then osteo induction, which is mainly will get in autogenous bone, and the DFDBA, the allograft coming from other humans. The osteoconduction, which will serve as a scallop, that will help the body come and build on this scallop, exist in all kind of bone graft materials, from autogenous all the way to the synthetic bone. So it's really important to understand the concept of building bone. And I like always to share, when we talk about bone graft, I like always to share this main small concept which will summarize everything in bone grafting. You will not be able to build any bone or to gain any height or horizontal or even socket grafting if you did not follow those principles. I call it the tent concepts in any bone grafting. Whatever the material you're using, whatever the growth factors, we have to follow this 9 materials that I talk about it as a concept of the tent. We need to follow everything we do in our camping tent to be able to build bone, solid bone, stability of the bone graft as we are building a stable tent, no mobility in the bone graft, space maintaining concept. We don't really need anything to collapse over our head as we put the tent with this post, middle post inside. Isolation from the surrounding tissues as barrier, perfect seal from the outside effects. We need primary closure just to make sure that we are building, especially with the GBR concepts, contained environment that we need to support our stability for the bone graft, and of course blood supply. If we don't have any, if we did not study the blood supply, it's not going to be any biology going on into the area. Firm contact with the underlying base. So it's very important. I see a lot of my colleagues, they put some bone graft without really touching the base of it. It's really important to build a base, especially when we're doing your big GBR, understanding the socket classification after the extraction is important. Clean environment, eliminating any infection or bacteria, and finally using some Autogenous material. So this is very important for our bone graft talk. We already covered this in our socket grafting with Dr. Rasner a couple of weeks ago, but I wanted just to touch base and make sure everything is great with whatever Dr. Ayoughi discussed. Reminder, we still have the last part 5 session in our implant study club coming up in May 13th with Dr. Brancho. We're going to be discussing the soft tissue management in dental implants. We're going to be touching base also with some of the bone graft techniques because of the soft and hard tissue connection between each other. This is the first part for our today talk. Thank you, Dr. Ayoughi, again for your presentation. I appreciate it. If you have any questions, guys, please don't hesitate to go and contact us for any questions. Again, back to the concept that I started the whole conversation with today. Preserving the soft tissue will support the bone underneath, and preserving the bone will support the soft tissue. One of the very important tricks that we have in hand to build a nice soft tissue is to use good temporization, sculpturing the tissues, and make sure we have solid and steady soft tissue. I have Dr. Ivancheva joining us from the UK. Dr. Ivancheva is a restorative dentist. She practices in Leeds at the United Kingdom. Thank you so much for joining us, Victoria, and I will give you the chance to share your screen. Looking forward to know more about your temporization tips and tricks.
Thank you so much, Dr. Yassin, for your kind introduction. It's a pleasure to be here, and I'm so happy to be part of your study club. I'm hoping today I can bring a little bit more awareness of what we do here. Just
Perfect.
give me a few seconds. Do you see my screen?
Not yet.
Okay, give me 1 second.
You got it, yes.
Perfect. Okay. As always, technology loves to play with us right in the middle of the important part.
Yes.
There you go, we have it. All right, so as Dr. Yassin kindly introduced me, I'm based here in Leeds. I graduated with my master's degree in restorative dentistry, and my passion to implants and my implant journey started when I joined the Bird implant course, which is a 1-year course provided by the British Academy of Implant and Restorative Dentistry. This is a few years ago, and our happy faces studying soft tissue graft for the first time. You can clearly see we're very excited that we don't know what we don't know yet. So in a few years later, we learned how much we didn't know. I want to give a shout out to a few of the amazing teachers I met in the British Academy. Dr. Roberetti, who is the guru of the aesthetic implants, and he taught me about immediate placement and what the risks are. Dr. Hassan Magera, who taught me the A's and B's of implant dentistry and everything that it is to know and all the secrets. And Professor Marco Esposito, who is the president of the Academy. He's from Italy, and they call him all around the world the policeman of implant dentistry. He's very well involved. Yeah, he's very involved into evidence-based teaching, and luckily having him on board taught us how to see the picture clearly, and not only to trust our instincts, and how to base all the decisions that we make on the evidence that we have. Getting to know Bird also opened the doors for me, and I got introduced to the international team of implantology, the ITI. I'm also a member of the Young ITI Academy, which is a branch of the ITI Academy. They started here in UK, but now I find out that they're international. I participated as a speaker for them in their ITI live sessions in London and in the ITI Tech Pods. It's actually very interactive, something similar to what your study club, I understand, is aiming for. And recently, ITI also joined WIN Network, which is I'm also part of. It is aiming to bring awareness to, and bring more women into the implant dentistry and support women throughout everywhere so they can get involved in lecturing and education as well. But primarily, my passion and what I really love doing is being a clinician. And here in Leeds, for a luck or a chance, we're actually having a wonderful summer. You might even hear the birds coming from the window, the bird noise is coming from the window. And this is our private practice. I work with a wonderful team. I'm very blessed to have them. I work together with Dr. Hassan Nagera, and this is Laura, who's our implant coordinator. We face everyday challenges, and the more we learn, the more we try to study everything, the more questions we find. So I wanted to tackle this problem today. What is the most important thing, and what actually connects us all? And my conclusion was, it's our patients. And luckily, we find a lot of these patients, especially here in Leeds, I'm sure in Seattle as well, that we call them the perfectionists. These perfectionists, they want to have the work done as fast as possible. They want it to be as cheap as possible as well. They want the result to be as natural, and they want it to be forever. So these are the patients that we really want to aim to please. And this is why we try to be the best as we can be. So how do we do that? I'm going to talk to you today about a concept called prosthetic soft tissue sculpturing, or as the Belzer and Bolzer team, they call it dynamic compression technique. It's how to replicate nature as good as possible. So when people see your final result, they wouldn't recognize which one is your implant tooth. And the way I see it, I got one day inspired riding the London Tube on one of my visits there. And I thought of this concept as being put together on stations. So to have a successful journey, an implant journey, starting from the beginning to the end, you need to stop at each of these stations. But if for some reason your train gets derailed or delayed by an accident or something else, you might never get to your final destination. And your final destination is where we're aiming to reach success. Today, I'm going to talk to you about a few of these steps. I'm going to touch base on some of these stations, but I'm mainly going to focus on the prosthetic soft tissue management. So, planning. When we talk about planning, we know that as an implant dentist, we need to spend a lot of time initially during our consultation, collect all the medical information about our patients, take impressions, make sure we have good study models, good wax up discuss how the treatment is going to go. So we're talking about prosthetically driven implant plan. But planning, my friends, also is a multifactorial decision, because this here is a result of false planning. So this lady had an unfortunate day, or maybe her surgeon had an unfortunate day in the office, because they've done everything perfect. They placed the implant in the correct position, they did bone grafting, they've done everything by the books. But what they failed to plan is their flap design. So the result of a bad flap design or a wrong made decision at the moment, that would lead you to poor results. In our private practice, we make the flap design a based decision on these questions. So we follow all these 6 simple questions, how to make sure that we achieve good soft tissue at the end and we avoid having mistakes. You have to respect the smile line of the patient. If there is high smile or low smile line, we need to make sure what GBR are we going to do. In advance, when we take our CBCT scans, we're going to know if provisionally if we're going to need GBR or not. And that means that if you're going to plan for a GBR, then you want to extend your flap design. What is your periodontal phenotype? Is it thick or thin? What are your adjacent structures? We all know that if we have an implant as an adjacent structure, we need to respect the soft tissue mucosa around the implant. Similar situation is for the crowns. We need to make sure that we know the biological width, and definitely we need to do a bone sounding before creating our flap. So in that planning stage, we don't only think about our prosthetic design, but we also respect the biology and respect all the tissues that involve our successful implant placement. The second station in our journey is the correct 4D placement. And this is something I'm going to bring you back to basics, because if we don't have a correct 4D position, then everything else we do, the most expensive zirconia abutment that we can place, it will still not fix the issue for us. So let me tell you the story of this lady. This is Star. She, at the time of her visit to us, was in her 20s, in her late 20s, and she had her upper central incisor missing for at least 8 years. She had an accident, but she was too scared of surgery, and she wasn't prone to have any implants at the time. So by the time she came to us, she had extensive bone resorption. So Dr. Miguero performed a bone block grafting to achieve horizontal and vertical dimensions. And later on, we placed the implant. So here you can see how was the thickness of the ridge and how much width you managed to achieve. We placed the implant in the correct position. So here, if we had placed the implant where the bone was at the beginning, then we risk placing the implant in the wrong position, which can put a lot of pressure on the labial plate. And we can deem ourselves to having a very anesthetic result. But building the bone in the correct position and making sure that we have the volume, we managed to place the implant in the correct position and to restore this implant to the high standards that this lady had. She had also a high smile line, so we were aiming to have perfect proportions of each tooth and perfect dimensions. So she was wearing a temporary tooth during the healing time. Then we replaced her temporary abutment. And here is where you can see with the bone grafting, we built the convexity. When we removed the healing abutment, we ended up with a circular emergence profile. And we gave her a temporary crown with the titanium base, screw retained. We also always aim to have screw retained temporary crowns because they're easy to retrieve and they're more hygienic for the patient. So gradually, after we proceeded with the soft tissue sculpturing, you can see once we achieved a good papillary result, we ended up having a customized impression. Here you can see the gingival margins. We managed to match both gingival margins. And this is what we want. We want to have a beautiful gingival zenith matching the adjacent tooth, not a circular one that could cause pressure in the future. We use some oxygen releasing gel that helps increase the disinfection in the area. And this is her smiling. So this is one of the cases that illustrates what I wanted to tell you in the beginning, what perfection really means and how these cases come to us and these patients have very high expectations. We customize the impression, and this is our lab preparing her final crown. This is our lab technician adding some porcelain layers one after the other. So the lady decided to restore her lateral tooth as well, just to give her, with a veneer, to give her a good harmony of her arch. This is her final screw retained crown. And this is the prosthetic, what the prosthetic soft tissue sculpturing could do for you. Here you can see that if we didn't have a perfect implant position, we could have never achieved a perfect result. So all these steps in advance to make sure we build the bone, to make sure we build the soft tissue around, and to place the implant in the correct position, that's what led us to bring her smile back. We use also silver plugs. They're based on silver nitrate, and they are still in study, but in clinical cases, people say that they are better as well for disinfection. And we cover the axis for the implant screw with a composite. So this is what Dr. Roberetti calls it a money shot. Here you can see that the convexity of both central incisor is absolutely the same. And you can see how we worked with the tissues and how we managed to match the white aesthetics as well. There is something that Professor Belzer calls a visual tension. So if for one or another reason, the final restorations doesn't match the characteristics of the adjacent tooth or the texture or the color of the area, that can cause a visual tension at patient smile. So we need to make sure that when they smile, they're happy to do that. And this is her 2-year review. You can see how much bone we achieved. This is her post-op CBCT scan. We placed a 4.1 implant with a 10mm height. And 2 years down the line, the bone is stable, the soft tissue is stable, and the patient is happy. So let's return to the main topic of tonight, which is the soft tissue. Soft tissue we can achieve by using our wonderful surgical skills or by using our prosthetic restorations. And today I want to share with you my experience, how we do it in our practice. So our clinical experience and how to use your prosthetic components rather than your surgical skills, in this case, the temporary crowns, to complement your surgical skills. So when we talk back to basics about the soft tissue, the most important thing is the soft tissue integration. And it is that relationship between the soft tissue itself and how the transmucosal portion around the implant maturates. When we achieve a good soft tissue integration, we aim to have healthy tissue, healthy implant, and good support for our final restorations. The pink aesthetic is important, and it's an essential prerequisite to have a perfect white aesthetics. As Professor Belzer says, unless we achieve good pink aesthetics, we can never achieve good white aesthetics. But achieving a good aesthetics is not an accident. And if we sit down and look at cases, we're not gonna, and we look at cases, maybe I like this tooth better, maybe Dr. Yassin likes the other tooth better. So when we sit down and look at cases, we have what we call a subjective view on how we assess the soft tissues. But to have an objective view, we use what we call the pink aesthetic score. It was developed by Fernhauser, and it was lately modified by Professor Belzer. That pink aesthetic score includes the mesial and the distal papilla, the soft tissue level, the soft tissue contour, the alveolar process, and the soft tissue color and texture. How we do that assessment, I'm going to give you here an example. So we score each of the points from 0 to 2. So if we are very happy with the result, we give ourselves a score of 2. If we are not sure we achieved perfect result, we give a score of 1. And if we're really if we really did something wrong and it was not successful, then we score 0. So this is an example of how I scored this case. I was very proud of the mesial papilla. It took quite some time to achieve both mesial and distal papilla. So we scored 2 in both of these. The soft tissue level, there's something we could have done better. So I wasn't perfectly satisfied with that area, and I give myself 1. If you talk about the contour, if you've seen the previous, if you paid attention to the previous photo, there is the alveolar process when I mentioned the money shot. This is where we're really aiming to achieve great results. So this one I gave myself 2. The soft tissue color, I think is relatively good as well, and the soft tissue texture. So I scored myself somewhere 13 from the score of 14. Well, you'll be glad to know that dentists are happy with the result that is more than 11 to 14. When it comes to patients, though, patients are happy with a score that is above 10. So we as a dentist are harder to achieve our goals than our patients are, which is a good note. So the pink aesthetics, we talked about how do we want to have a perfect 3D position. If you'd like, you can also use the modified score by Belzer, which focuses only around the soft tissue. So you have the mesial papilla, the distal papilla, the facial mucosa, the labial facial mucosa, and the root convexity, whichever one you find easier. So to achieve perfect soft tissue, you have 4 options. You need to have a perfect flap design. As I mentioned in the beginning, you want to have tension-free suturing and tension-free closure of your flap. You want to have good surgical. If you need to do any surgical soft tissue grafting, you can do that as well. Or you can achieve it how I'm going to show you now with your prosthetic soft tissue sculpturing. So the story starts as perfect implant positioning, doing GBR or soft tissue graft. And then when we talk about the prosthetic design, we talk about what we call a transitional zone. So how to replicate that tooth to match the natural tooth next to it. The transitional zone is what we see when we talk to people. It's the front area that consists of the perfect gingival margin, the equal zenith, a healthy emergence profile, a very tight and good gingival seal. We want to have labial convexity, so that can match the natural teeth adjacent to it. And of course, we want to achieve good papillary support. So once we reach to the second stage where we have the exposure, this is where we have a healthy, beautiful implant, but we have a circular emergence profile. So at this point, you can choose to take your final impression. But if you do so, in this case, you're basically forcing your lab to guess where that emergence profile would be. And you can end up with something that we call potato on a stick. So a very narrow opening with a very wide base. Or your lab technician cannot achieve the perfect triangular form that you would like to have in this case. And if that happens, you are putting yourself in a position that you might have necrosis or even recession. So how to make that circular form achieve the beautiful triangular form that the central incisors have? We're always using a screw retained crown because screw retained is easier to retrieve, and we use it made of composite because composite can be polished perfectly. How do we communicate with our patients? We talk to them that this temporary crown is going to be used as an aesthetic try-in during their healing period. It will also be used as a very good communication tool. So for example, this lady, she used to have a diastema before she lost her tooth. And we had to offer her different options. So she wasn't sure, would she like an ovate tooth? Would she like to keep the diastema or remove it? Would she prefer a triangular one? So the temporary crown can be used as that communication tool between yourself, your patient, and your lab technicians as well. We use, as I mentioned, composite. The composite needs to be perfectly polished. And we gradually build the contour. So after we polish the composite, we also, a little trick, we use some glycerin. We like cure it through because that helps the soft tissue to reattach. So how do we do the gradual contouring? We do it through around 4 to 8 and sometimes to 10 weeks. And we do it between 3 to 4 visits where we gradually build the contour, adding composite to the areas. And this is what I want to share to you today. It's what we call in our private practice in Leeds, the 7 secrets, which are not really secret, but the 7 secret steps of how to achieve a perfect prosthetic design. So the first step is the supragingival convexity. You want to have a supragingival convexity so that can deflect the trauma away from the tooth. You want to have a subgingival concavity because the concavity can be used as a dead space, and that area does not put pressure on your soft tissue. And also that dead space can be filled with granulation tissue that you can later on use without having to have any soft tissue graft or anything extra. So biology helps you. You want to have a contact area, perfectly positioned contact area. And when we talk about contact area, we need to mention the study done by the Salamo brothers in the Atlanta team, because you always need to respect the adjacent structures. As they mentioned in their study, when we talk about a papilla between an implant and a pontic, are we talking about a papilla between 2 implants or a papilla between an implant and a natural tooth? So that contact area needs to be perfectly positioned accordingly to your adjacent structure. The 4th step is you want to create a conversion profile. So you want to have the cingulum region to be narrower than your labial region. In that way, you don't put pressure and you don't crush your papillae in the palatal region. So you want the lines to be converging towards your cingulum. The sixth point is having a tight gingival seal. That way you can achieve more hygienic profile. And how do we do that tight gingival seal? You can extend your temporary crown to about 1 millimeter subgingivally to achieve that good tightness. And how to achieve a perfect zenith? As I've shown you, we use the composite to start gradually contouring the zenith. So not to put pressure all at once, but gradually build that profile. And the seventh step, this is something that we mentioned about the visual tension. You can use your vertical and horizontal lines, or your lab technician can do that for you, to make sure that your tooth is either looking wider or narrower. So to summarize, you have the 7 secrets of successful prosthetic soft tissue sculpturing. And why we do this, we want to make our crown to look as natural as possible, and how to make sure that we preserve the soft tissue as well as we can, and to gradually contour without putting too much force on the soft tissue and on the bone. So we want to, where we started from here to here to there. With 3 to 4 visits, you can achieve that result yourself. So only here, when you have a perfect triangular, which you can have in the central incisor, only then you can take your final impression and send all this information to the lab, where they can replicate the nature the same way as it is in the patient's mouth. And once you achieve a perfect pink aesthetics, then you can work on your white aesthetics so you can match everything and achieve a perfect result. So this is the patient with her final screw retained crown. She decided towards the end of the treatment to replace her crown on her lateral as well. And we customize, as I was telling you, we customize the impression pickup. Why we customize it? Because once you've done all this hard work, once you've recreated all the soft tissue contour, once you push the gum where you wanted it to be, you need to make sure that all that information goes directly to your lab. So you need to transfer all that to your lab technician, and during your impression taking technique, you want to make sure that the soft tissue profile is very well supported. How do we do that? We use impression copings, and we use flowable, and then we replicate what we have in our temporary crown in our impression pickup. We cover it with the impression material, and we use an open tray technique. And you can see here, sometimes if a little trick is sometimes the implant is placed too deep, you can use the adhesive and put it on your impression coping. That way, when you take out the impression, it will all come at one piece. So you don't risk it moving around. Okay, we fit the final crown, and we do occlusal adjustments. Make sure there are no lateral forces. And there you go. So, because we are in this beautiful study club, I wanted to give you some evidence-based knowledge that you can take, because so far I can tell you what I've learned from our experience and how we do it in our practice. Unfortunately, the evidence is not a lot in this topic, and I found few relative studies that I wanted to share with you. The most relative study is a randomized controlled trial done by a very good clinician, Dr. David First from the United Kingdom. He collaborated with the University of Bern, and what they've done, they wanted to find out if they can use, if the use of the provisionalization leads to any benefits. Because we all know that it involves quite some time, it increases the cost to yourselves and to your patients. So how they've done that, they've used 20 patients with bone level placed implants, and they divided them into two groups. One group had a provisional crown with the technique we've just described, and the other group did not receive any provisionals. And 1 year later, so they assessed the pink aesthetic score and the white aesthetic score at the beginning, and then 1 year later, they assessed again the scores, and they did x-rays, assessed them that. So what they found out, 1 year after the examination, the WES results, they had significantly increased, and the PES results as well. So once they've done their statistical analysis, they concluded that within both groups, the p-value or the final value approximated with these two numbers is statistically significant. So using the temporary crown in the first group make a big difference within the WES and the PES score. 3 years later, they revisited the patients again, and the examination shows that they had very good PES score again. The WES score didn't make a statistically significant difference in this case. Okay, and their conclusions that both cohorts, that they had the fixed implant supported provisional, they had statistically significant higher PES and WES score, and comparing to the other ones that the implants were not restored with provisional. And this is another study I wanted to talk to you about that supports this theory. So if you do a classical approach and we go to that circular emergence profile after we remove our healing abutment, our final restoration at the moment will put pressure on the gum. And if you have thick biotype, that soft tissue might adjust itself and will heal okay. But if you have thin biotype, then you risk having recession or even necrosis. So once you do gradual soft tissue maturation, you increase the volume of the soft tissue. So this study aimed to analyze the dimension of the mucosa after using the prosthetic provisionalization. And what they concluded is that there is a statistically significant increase of the volume of the soft tissue. So what we do, we actually displace the soft tissue, and that way we increase the volume. So the individualized mucosa and the emergence profile, they were have the fixed provisionalization, and they can clearly show that the volume doubled in size once they've done the measurements. I want to show you a few examples, clinical examples, the good and the bad, because we always learn from, not only from the great cases that we managed to achieve beautiful outcomes, but we learn from the bad as well. So this lady came to us after her implant restoration done somewhere abroad, and she felt discomfort in the tooth for quite some time. The moment the crown was a bit loose, so the moment we tighten it, we see that the soft tissue present with that blanching and discoloration. When we remove the crown, so see here, the profile, we needed to adjust the profile. There you go. So when we remove the crown, you can see that the emergence profile was very concave rather than convex. which give the soft tissue that pressure and that blanching effect, and that caused the patient discomfort. So we needed to adjust the gingival margin, and we adjust the subgingival profile. We send everything back to the lab so they can glaze it. And this is the final result. So that bring the patient and the soft tissue back to normal. This is another success story of a young patient. He's actually a teacher in grad school of one of the Leeds University schools. He had a big shape lateral, and it took him quite some time. He wanted to keep it as long as possible, but the tooth couldn't survive, so it needed to be removed. We placed an implant. We placed an immediate implant, a 3.3 Straumann implant, because as you probably discussed in the immediate session, we followed all the risk assessment, and we took all the steps to make sure there's no chronic infection, that there's good labial bone, and to make sure that we have a successful immediate implant placement. We placed the implant as palatal as possible within the socket to be in the correct 3D position, and we managed to achieve good high torque. So we decided to restore this implant with a provisionalization at the time of the implant placement. So we did an immediate placement and immediate loading. We use a titanium base abutment, and we use patient's own surgical guide to recreate the shape of the tooth. And here you can see the subgingival concavity that will help the soft tissue mature and will support our graft as well. We use layering technique. So we use a combination with autogenous bone, allograft, and xenograft, and we cover it with a membrane that is very well stabilized. And we suture everything together without any pressure. Okay, and this is the case 1 week post-operative with the temporary crown. We gradually adjust the contact points. We give the tissue some space in the beginning, and then we gradually contour the contact point and the subgingival profile. And this is the X-ray. This is 12 weeks after placement. You can already see that the profile is changing, that they already see how the soft tissue take the form of the natural tooth. And this is at the time of his final impression. We customize the impression pickup the way I showed you earlier. We fit the impression pickup, and at the time of the impression, he decided to put a veneer of his adjacent lateral tooth. So we've done them simultaneously. We used the Straumann CAD/CAM abutment. We did proper isolation to cement the veneer. We fit the abutment as well. And this is the final result. Okay. So you can see how we achieved a harmony between what he had in the beginning. We gradually contoured the soft tissue to match the margins of both lateral teeth, and this is his final result. We've done a post-op X-ray And I'm sure, I think we have a post-op CBCT of that case as well. Do we still have some time, Dr. Yassin?
I think we
You
we're
actually,
fine.
you're
Yep.
yeah, you're
Really?
fine time-wise. We don't have anything after, so you guys,
Perfect.
you just need to be done by sunset.
Okay. Okay, that's a great. Yeah. So
Perfect.
I thought we have another lecture coming. So thank you, Dr. Hess. I think you take your time. I think it's a great discussion. I have a lot of comments and questions. So go ahead, finish your lecture,
Perfect.
take your time, and then we can continue the discussion afterward.
Perfect. I wanted to finish with my lifetime message. This is a video I found online that actually depicts what the philosophy I started in the beginning for. So we talk about perfection, right?
And it looks great. And now more than ever, we're flooded with it in our Instagram feeds, in ads, and even while watching TED Talks. But what we see is often just an illusion. Instagram shows only the moments, angles, and outfits that their creators choose to showcase. Ads are created by teams of experts that are paid to get us to want what they're offering. And even the sacred TED Talk is given by the most gifted communicators who have often put years and years of research into the work they are presenting. And if you were to ask those Instagrammers, advertisers, and TED Talkers if they feel like their latest post, billboard, or presentation was perfect, they most likely would say no. Even when Isaac Newton saw the first edition of his book, Optics, a book often considered to be one of the greatest works in modern science, he had his name removed from the title page due to the imperfections he believed to be in it. He didn't want to be part of something that wasn't perfect. Perfectionism is when a person refuses to accept any standard short of perfection. So as a perfectionist, if you're a runner and you qualify for the Olympics and make second place, you don't think of yourself as the second best runner in the world, you think of yourself as a failure. Voltaire said that perfect is the enemy of the good, meaning that if you strive for perfection, you are destined to fail because perfection simply doesn't exist. Even when you write a sentence you find perfect today, you might hate it tomorrow. Perfection leads to an endless and impossible cycle of reworking sentences, photographs, ideas, or whatever it is you want to be perfect. Individually, this often causes anxiety and a non-acceptance of yourself and your imperfections. And it has even been linked to suicide.
So what's the cause? We know that perfection can lead to a lot of negative results, and we always strive for that perfection. And I started this presentation talking to you about the perfectionism between our patients and the perfectionists that we are ourselves. So the solution is something called excellentist. And what the excellentist is, this is someone who, even if they fail, every failure becomes an opportunity to reflect and to become better. So in some situations in life, although we strive to do everything as possible, what they say is that you could just say to yourself, I did the best I could, and that's good enough for me. So I hope all of you strive for perfections, but be excellentists. So at the end of the day, we achieve the best result as we can be. Thank you so much. I really enjoyed talking to you today and sharing my knowledge and my experience. I really hope this presentation can bring something to you. And I look forward to your questions.
Thank you so much, Victoria. That's an excellent presentation. I have a lot of questions coming on, and I wanted to get your opinion or your thought about, we have different levels from our attendees right now. We have some advanced people, we have some specialists, we have general dentists, somebody with the beginner level. I have a lot of my colleagues in the program, all my doctors, they are attending. So I just want you to make sure that you are dividing the different topics between immediate implant placement and immediate temporization, and delayed implant placement with the temporization at the second stage. So can you just touch base, because like some of the studies that you showed, they are absolutely correct, but they are taking the delayed implants,
Exactly.
temporization. They have nothing to do with the immediate
With
implant.
the immediate.
I
agree.
will follow up with a little bit of my slides at the end, but I want you to just make sure you're explaining the difference between immediate implant, immediate temporization, and delayed implant with temporization at the second stage.
Absolutely. So there are two different approaches, but using the same technique. So the way you recreate your temporary crown, it wouldn't make a difference what is your implant placement. However, we always need to respect the implant integration and the implant osseointegration. So if we have an immediate implant placement, and if we had achieved a very good torque, then we can use a temporary crown to complement our soft tissue graft, our bone graft. Some people even use their temporary crowns to support that graft in order to help the soft tissue contour even better. If we're using prosthetic soft tissue sculpturing with a delayed implant placement or with a delayed implant loading, then we take these steps even more gradually. So it takes us about 3 to 4 visits to gradually contour the prosthetic and the emergence profile to achieve the same levels.
Perfect. It's really important to distinguish the difference between two things. One of the questions came to me about immediate implant placement, and when do you prefer to do like full temporary restoration or customized healing abutment? Of course, the obvious question with initial stability, but what is exactly your take about this concept in immediate implant and immediate temporization?
Well, as you mentioned, if we do achieve good implant support and if we have good torque in the beginning, I'm more than happy to go to having a final temporary crown, because the sooner I have the final or the provisional design of how the tooth is going to be, the more that is going to help the tissues grow and mature the way I want them to contour. In situations where we don't have good stability, we can use the customized abutment, but the customized abutment has its downsides as well. It doesn't give a perfect support on your tissues, and in time, your tissue matures and changes. So if you're using the sooner you can get to use your temporary crown, the easier that is going to lead your soft tissue.
Yes, absolutely. We have some questions coming off. Do you prefer any insertion torque to decide any numbers, to decide whether you want to do the whatever we call the immediate loading or the other way of going with customized healing abutment?
Well, there are some good evidence that suggests the safest option is above 32 or even above 35. I've seen people do immediate loading even at an earlier stage, but personally, I'm not comfortable and confident doing that. So, yeah.
Perfect. One questions also came about, you mentioned this in the lecture about the importance of following the screw retained temporary for the retrieval, right? What's your comment about especially in temporary restorations, if we want to use cement retained? And I have several questions coming on this. I have my opinion about it, so if you can share your knowledge also, that would be great, please.
Well, in my experience, I've always tried to avoid cement retained restorations as much as possible. Using cement retained restoration for your temporary can make it even harder for you, because retrieving that crown and having to add composite to it, you can never put it back, or you risk not putting it back at the same place. And always having the access cement as well is not a bonus. So the more we can avoid it, the better. Having said that, in some situations, you end up having the screw axis coming close to your labial surface. But with a temporary crown, you can always mimic that by using proper composite or using pink composite to mask the metal shadow as well. So I always use screw retained crowns. For me, it's a prerequisite.
Looks like you have a great surgeon then, right? I believe Hassad is the one who's placing this for you. Great. Let me go a little bit in depth. And I know recently, for probably the last 5 to 7 years, in the pros literature, we've been reading more about one abutment concept. And the main idea is trying to minimize the irritation between the abutment and minimize the detachment between the soft tissue and the abutment.
Yeah.
Some colleagues went all the way to the idea of placing one abutment one time, and that's it. Don't really take it on and put back and adjust it. It's really nice concept, but practically as a surgeon, it's a little bit hard to just achieve whatever you want from the first shot. It's amazing to try to preserve the attachment between the soft tissue and the abutment. But from your perspective as a restorative dentist, what's your take about this one abutment, and what is the pros and cons of this concept versus trying to sculpturing the tissues around?
Well, there are randomized controlled clinical trials that they show that using a one-time abutment and not removing the crown so often can only make a difference of about 0.5 millimeter, which is not very clinically significant. It might be statistically significant a lot, but at the end of the day, we want to make sure that we achieve the best result to our patients. So if we use one-time abutment, we have to predict where the tissues are going to heal. And I find that using an unpredictable technique, it doesn't always give you the perfect result. Yes, you might get lucky, you might achieve everything right, but at a cost of having a wrong prognosis, then that really disappoints your patients in the end.
Yes, absolutely. I totally agree. And it's important to take two measures. Like it's really the concept of doing temporization is really connected with the stability of the soft tissue. So this is why soft tissue grafting, and as I started my whole discussion today, is the link between the hard tissue and the soft tissue. This is the goal. We need to do stability. So we can't really do anything without the other way around. Another question, how long do you allow the custom healing abutment to mature before you take it to a screw retained temporary?
The custom healing abutment, sorry.
How long do you allow the custom healing abutment to heal around? This is what he meant, before you take it out and change it with the retained screw retained full temporary abutment.
Depends on the case. That's one of the beauties of this technique, that you get to control your soft tissue maturation. It depends on your soft tissue phenotype. Sometimes it's easier to achieve the soft tissue maturation and quicker, and sometimes it takes longer. But on general, I think usually we leave it around 20 to 24 weeks. I've been part of Professor Belzer's education week in Bern as well. And I know that they leave it there for much longer. They leave it until 6 to 7, 8 months as well. So depends on how stable your temporary crown is going to be.
Right. Amazing. A lot of good discussion. As I told you before, I will share my 2 cents in a minute. I wanted to thank you very much. Dr. Ivancheva already provided her email address. If you have any questions, feel free to reach out to her and to me. We'll continue our discussion. I will share my screen right now with a couple of. I know you had a lot of background from the ITI group. I think the ITI treatment guides, I think it's in the back here with me. It's like it's my Bible for a lot of work here. So thank you. I wanted to share this from the same group actually doing the can you see my presentation here?
It's a bit blurry, but I think we can.
Okay, let me
Yeah,
see here.
we see it, but it's not. Yeah, there you go.
Perfect. So, you know, as Dr. Ivancheva discussed, it's really important to understand that there's 2 different concepts: immediate loading and immediate placement. And when we're talking about immediate loading, it's all about some factors, considerations. We never have an implant too heavily loaded into function directly after placement, especially when we're talking about single implant placement. It's a different story when we talk about a group or full arch splinted implants. But when we're talking about immediate loading, that means that we have implants with temporary, immediate temporization, but they are off occlusion. So we are not really applying a lot of effective function on them. This is some of the considerations for us to know what loading concepts we can the factors that will influence the decision for us. Are we going through some immediate loading into the implant after placement, immediate temporization, the general health of the patient, the intraoral condition, if we have any periodontal status, the bone volume, the bone density, most importantly, the initial stability of the implant, the biomaterial related factors such as the implant size and shape, the connections that we have between the implant and the abutments, and of course, your choice of treatment, the necessity of bone augmentation if you want to do bone on it, and finally your skills if you are well trained to go ahead and do immediate implant placement and immediate temporization. So it's really important for us to understand. I always say follow the manufacturer recommendations for your immediate loading or how much you feel more comfortable. In the literature, we know 30 to 35 Newton centimeter as an initial insertion torque is really important to achieve before considering immediate loading. Now, I know Dr. Ivancheva touched base with the direct temporization over implants, but also I wanted to share this with you, types of different temporization. Not all the time we can go ahead and do temporary teeth over an implant if we don't have initial stability, if we have some bone grafting going on, if we don't have soft tissue ready. One of my good to go or the first option for me is this simple Essex for temporization. I love this concept. The support comes in this Essex with some teeth from the teeth around it. So we don't have any support from the soft tissue. The site of the implant of the surgery would be supported and would be like, you know, we don't have any pressure on it. So we don't really have any forces coming into the work with it. The indications, it's a lot of indications. We can do it for long span, so probably 2 to 3 teeth maximum. For aesthetic zone, it's really important. One of the advantages it's really will give the patient good feeling. We can use it as a suck down stent to protect the palate if we did some soft tissue. It's unfortunately it's not durable, so it's gonna start to wear after a couple of weeks. So usually when I go with aesthetic areas, I start with this Essex, the suck down stent, and then I upgrade it down the line into the regular denture or a partial denture or flipper. It has some issues with the lip line. If we have a hey lip line, it's not too aesthetic, but usually the patients will love it more than having a partial denture. The other way to go is this using regular partial denture or like the acrylic stuff. Unfortunately, it has some support from the soft tissue, so we see all the time that after the surgery, it's more possible to have some pressure over the area of the surgery, which will cause a little bit of issues down the line of the healing. Valplast Flex is one of the things that could be used. And finally, if you have any bridges or prep teeth around the area, you can use the fixed prosthesis. So we have a lot of options, but the main thing that Dr. Ivancheva was talking about is the temporization over immediate implant. One of the questions came to us was the immediate implant placement and how to bury the immediate implant. We discussed in details immediate implant last week with Dr. Katafuchi in the immediate implant session. One of the most advantages of having immediate implant placement is the possibility of stabilizing the soft tissue in the area. And we can stabilize the soft tissue with the means of one, some kind of restoration, like custom healing abutment or temporary full restoration, and also with using some soft tissue grafting into the area. So if you want to go the route of doing immediate implant placement, try to get this skill of doing this small steps of preserving the soft tissue around the area, especially if you have nice soft tissue around this around the tooth, like we have in this case at the tooth number 8, tooth number 11. So as you can see, extraction, we have nice soft tissue. You can feel that the emergence profile is already can be maintained in a good way. And in this case, I chose to do custom healing abutment. I use this metal provisional abutment that will help me with going a little bit more durable. It's longer. I can keep it for at least 6 to 8 weeks, so I can shape my soft tissue. So implant placed, initial stability, and you put this provisional abutment. It's the metal one. There are in the market, there are a lot of other plastic or peak abutments that can be used. I prefer to do this because I can use the composite to shape the emergence profile that I use. After placement, we use regular composite, and I just follow the contour of the soft tissue surrounding the area just to try to take my impression. And after this, you will end up with some kind of the temporary custom healing abutment. You'll have this voids that you need to follow and fill up with your composite to make sure you're getting with the contour for the healing abutment there and the emergence profile. And finalize everything with good finishing for the area. Just try to make sure that you are finalizing and smoothing the composite that you have and fixing the whole step with the good insertion torque. It's important for us to, whenever we use healing abutments or custom healing abutments, to torque this healing abutments to the manufacturer recommendation. A lot of time, because of immediate implant placement, we'll have some interruption between the abutment and the crestal bone surrounding the area. So we need to reshape the bone in the way that we can place the abutment in place without having any complications of losing the abutments down the line. So after that, we just get to the point that we leave this custom healing abutment for 2 to 3 months, so we can reshape the soft tissue. If needed, if we want to do any of the soft tissue grafting, it's really important to consider it probably at the same time of the surgery, or down the line if we need to do some more augmentation. This is how the custom healing abutment will look. You can see after several weeks, we have the soft tissue already supported, stable. The level of the gingival margin is good, and um, in the radiograph, you can see the connection between the abutment and the fixture down the line. It's really solid. I think that's it. We have a lot of this talk. I wanted to just insist on what Dr. Ivancheva talked about, the S shape of the emergence profile sculpturing. Whenever we do, in this case, I use the same tooth of the extracted tooth, the crown, to be used at the same on the provisional healing abutment. So I'm connecting the crown into the abutment with composite. You will end up with some kind of gap between the crown and the abutment. I use some radio or some opaque material, the resin here, to block the metal effect and the gray shadow that we can have down the line. And then you create this S shape. Make sure that you're getting more space for your soft tissue to grow into, especially at the level of the implant, and using this after smoothing to preserve the case. And in this kind of cases, like the patient came with a trauma, a fractured tooth, a central incisor, and he came out of the office perfectly done with the same crown at the same visit. So it's a great service for us, especially with aesthetic zone. So we kind of make sure that we provide the services for us as much as we can. If I don't see if you have any questions here, let me take a look. I think yes, we have some questions. I hope that I covered the answers for this. Any comments, Dr. Ivancheva, for what I've just shared actually here?
No, absolutely perfect. Dr. Yassin, I think we do completely similar approaches. We have similar concepts and ideas, and the result is visible. You achieve perfect aesthetic result. So
yeah, well, I mean, in the aesthetic zone, it's always important for us to you know, to know that it's not always, as you said, there's a difference between the perfectionist and excellentist, right? So we're trying our best to achieve as much as we can. Anyhow, I want to thank everybody today for the attending this amazing lecture. Thank you, Dr. Ayoughi. Thank you, Dr. Ivancheva. I really appreciate your help and your work. We'll keep in touch. We will try to do some part 2 if we have a lot of other comments there. So I want to just share with Dr. Hess, if you don't mind, I just want to share with the everybody just for a minute about our courses here coming and May 13th we have Dr. Brancho coming with us talking about the soft tissue management. It's going to be connected to what we discussed today. We're going to be discussing also some of the bone graft techniques as well. Again, we are here in Seattle. We're proud to have this great clinical implantology from A to Z program. It's 10 modules starting in September 2020 until June 2021. If you have any questions, reach out to me or to the Washington Academy of General Dentistry. It says almost 300 hours CE work for us, clinical work, surgeries, hands-on. It's unique because a lot of doctors, they participate in doing surgeries, and you can not only, you can pick and choose if you want to go take the whole program in 10 modules. You can do it. If you want to take some modules, that will be absolutely feasible as well. So thank you again, Dr. Ivancheva and Dr. Ayoughi. And thank you, Dr. Hess, for your work. You can take over right now, and I appreciate it. Please feel free, if you have any questions, to reach out to me and to Dr. Ayoughi or Dr. Ivancheva, and we're more than happy to answer your questions. Thank you, guys.
Thank you.
Thank you, Dr. Yassin. Thank you for our panelists today. Appreciate you spending the time with us. This is the Washington Academy of General Dentistry Stay Home, Stay Healthy CE series. We just updated some of the flyers that you can see going by. On Monday, we're going to have both suicide and opioid training that is for the requirements for Washington State here. We'll have that up on our website very soon at washingtonagd.org. If you're an AGD member, those courses are free. If you're a non-AGD member, those courses are going to be $50 each. We weren't able to reach any outside sponsorship help with putting those courses on for our speakers. Just a reminder that we do have our orthodontic program starting in the fall. Tuesday, you want to see Dr. Marcus Troll speak on aerosols. He just does a fantastic presentation. And then Dr. Karbash is going to be back in the afternoon answering questions from her webinar earlier today. We forwarded her all those questions, and we'll be having her go through and answer those questions as thoroughly as she can. Obviously, things are evolving, and we may not have the answer, and the answers may change here in the next week as well. Thank you to all our sponsors, Comet USA, Patterson Dental, University of Washington School of Dentistry, the Canadian Academy of Restorative Dentistry and Prosthodontics. And this finishes up our week of webinars. Appreciate the help from the International Academy of Anathology, Dr. Paul Hasegawa putting that group together. On Tuesday, Dr. Kenton Ross from Arkansas put on the Arkansas AGD Day. So thank you for the speakers. And thank you to Dr. Peter Thompson from Nova Scotia, the president of the Canadian Academy of Restorative Dentistry and Prosthodontics, for putting on Card P Day yesterday. Yeah, Dr. Mark Donaldson's going to be with us on Monday on opioids. Dr. Chad Bergdorf is going to do the suicide presentation, and those will fulfill your requirements to the state of Washington for your suicide and opioid training. Dr. Yassin mentioned clinical implantology from A to Z is starting up in the fall again. 240 hours of CE credit. If you missed any of our webinars, the webinars are available at YouTube at Washington Academy of General Dentistry. If you have trouble navigating there, just go to washingtonagd.org, look for the YouTube link, and click on that. We literally added a bunch of webinars here over the last couple hours for next week. We're packed full. And so that's why you don't see any QR codes on here. If you go to our website tomorrow, you will be able to register for all of those webinars. You'll see some of them have the WAGD Stay Home, Stay Healthy CE series. Those are as a courtesy to any dentist out there that wants to watch those. Your CE credit will be coming from the University of Washington School of Dentistry. Your CE credit should show up in your email inbox within the next 2 to 3 days. Just a reminder, if there's any problems there, contact the University of Washington School of Dentistry CE department, not the Washington Academy of General Dentistry. For those of you that are AGD members, your CE credits will be reported directly to the Academy of General Dentistry and show up on your transcript within 2 to 4 weeks. I think that about covers it. Thank you again for everyone that's joined us. Thank you, Dr. Yassin. Appreciate it. And
Thank
we
you so
look
much,
forward
Dr.
to
Hess.
seeing you
Yeah,
next week.
absolutely. It was a great session. We had almost 600 participants. Thank you, Dr. Hayamoto. We had 600 participants. We answered effectively almost 160 questions, either by typing or by talking. So great session. Thank you, guys. We did great. Thanks for the participants, and thanks for the doctors, for everybody here. And we'll keep the conversation going. Okay.
Thank you, and say hi to everybody in Leeds there. I did an oral surgery externship there in 1993.
Wow.
So, and I haven't been back yet, so I think it's probably safe too. The you know, the air is cleared. I'll probably be welcome back now.
Always.
Yeah.
Of course, you should definitely come again.
Is the Faversham pub still there?
Yes, it is.
Yeah. Okay. Well, we'll be back then.
Perfect. Let's go to Leeds. Let's go to Vancouver first, Canada, and
Yeah.
then we'll go to Leeds. So, okay, guys, thank you so much. Appreciate it. Say hi to
Thank you,
everybody in
guys.
Canada and UK, and we'll talk soon.
Have a great weekend. Thank you,
Thank
Dr.
you.
Hayamoto.
Thank you,
Bye-bye,
everyone.
guys.
Great session. Thank you for having us. Have a good day.
You're welcome. See you soon.